Hello everyone. First off, I'd like to apologize. I have a cold right now, so that's why I sound congested. Um, so to get started, I decided to do factitious disorder. A lot of people refer to it as Munchausen syndrome. I decided to do this because at work, well, first off, I work at Shadow Mountain Behavioral Health System. It's a psychiatric hospital, predominantly working with children and adolescents, and I work on the acute pediatrics unit. And so they're just in for stabilization, get on meds, get some therapy, get some stuff set up, get out. Anyways, the past couple weeks we've had some kids who have been pretending to be sick, and they'll they'll throw themselves off of a chair and be like, "Oh, I hurt my ankle," or something like that. There's really nothing wrong with them. They just want the attention, I guess. So when I saw this on week 2, I was like, "Oh yes, I'm definitely going to do that." So the diagnostic features, first of all, I'll talk about the DSM-4 and then the DSM-5 just to kind of talk about the difference between the two. I think it's kind of interesting, the differences. So with DSM-4, factitious disorder is in its own category. And there are subtypes. There's with predominantly psychological signs and symptoms, predominantly physical signs and symptoms, then a combination. In the DSM-5, they wrapped all of factitious disorder into the somatic symptoms and related disorders. And there are no more subtypes, but there are specifiers, and they are single episode or recurrent episode. So, the diagnostic features. There's 4 main diagnostic criteria. You have falsification of physical or psychological signs or symptoms, or induction/injury or disease associated with identified deception. So a big key thing here is the deception, the falsifying of information, the lying. The individual presents himself or herself to others as ill, impaired, or injured. The deceptive behavior is evident even in the absence of obvious external rewards. That's another key factor to this, is that there are no external rewards whatsoever. The behavior is not better explained by another mental disorder such as delusional disorder or another psychotic episode. Specifiers I previously mentioned. Single episode, recurrent episode. So, I'm sure a lot of you have heard of Munchausen syndrome by proxy. In undergrad, I looked at this a couple times and watched some videos, and I was kind of freaked out by it. So, I'm kind of glad I'm doing the presentation on it. So, factitious disorder imposed on another is its technical name in the DSM-5. But that is pretty much the same thing, except instead of you being sick, you place it on someone else, and they're the sick ones. So, typically what is common is a parent will pretend their child or dependent is sick or ill or injured in some way. So they might, let's say, put the baby under a heating lamp for a little bit before they go to the doctor so they're warm so they have a fever. Or they might hit the baby to bruise it, or they might pinch it to make it cry, they might shake it, something along those lines. Even just simply taking the kid to the doctor over and over and be like, "Oh, he's been doing this or that," and maybe pretending the kid is unstable mentally or something like that. So that is factitious disorder imposed on another. Now it is very important to clarify that it is not the person who it is imposed on that is diagnosed, it is the imposer that is diagnosed. Again, there's specifiers. They were already mentioned. It's single episode or recurrent episode. Associated features and conditions. So, inducing psychological or physical stress as well as possible injury to self or others, that can be pretty detrimental. Not so much the psychological symptoms or whatnot. That's not that big of a deal. Just pretending "Oh, I'm crazy," or "Oh, I had a psychotic break," or something like that. That's not that big of a deal. But a physical stressor where you injure yourself, that's a big deal. So a lot of times, not a lot of times, sometimes what people will do is say they have an IV in their arm. They might scratch the IV site to get it infected, or they might take laxatives so they get diarrhea, or they might take some other pill to make themselves vomit. They might sit under a heating lamp before going to the doctor to have a high temperature, something along those lines. Now, some of you might be thinking of malingering, which is similar to this. It's where you're making it up, but there are obvious external rewards. For instance, someone might go to the doctor complaining of chronic back pain so they can get narcotics and pain relievers, or so they can get off of work on pay, or so they can get disability, something along those lines. There is an obvious external reward for it. It does share some features with some personality disorders, particularly when it comes to the deception of it all. There might be criminal behavior with it, more so with Munchausen syndrome or factitious disorder imposed on another. That's pretty apparent as to how that can be criminal behavior. If you are abusing or neglecting your child, because neglect, that might be another one where they just don't feed them enough so they get sick or something like that. It's pretty obvious that that might be criminal behavior. So if that is the case, call DHS. It is different from somatic symptom and related disorders and the other somatoform disorders because those symptoms are not falsely produced on purpose like this disorder. So for instance, if someone has a somatic disorder of some type where, let's say, they have chronic back pain because of a psychological problem, that pain is real. They have a real pain. It is not made up like this. This is, the person is deliberately making it up. Again, with no external reward whatsoever. And now the history of it's kind of interesting. We talked about the Roman physician Galen. He was one of the earliest ones to note someone making up a disorder of some type. On feigned or factitious disease. So again, on feigned or factitious disease, sorry about that, I had to attend to my dogs for a second. That is a book published by an English physician. His name was Gavin in the 1840s. That's the first instance of factitious, the word factitious being used for this disease. Munchausen syndrome, as a lot of people refer to it as, was first talked about by the English psychiatrist Richard Asher. He's the one who gave it his name, or its name, and that is referring to Baron Munchausen, who was a German baron, and obviously, commonly made up war stories, adventure stories, what have you. Hysterical disorder. This would have been under hysterical disorders back in Freud's time. He probably saw a little bit of it because of the whole hypnosis thing that we talked about, where he was interested in that, where people could produce hysterical symptoms like illnesses and whatnot because of hypnosis, and then they could go away. So Freud may have came across this disorder. The prevalence of it is actually unknown. I'll talk about why here in a second. It's estimated at around 1% of people actually meeting diagnosable criteria. More common in women than in men, which is interesting. Onset, early adulthood, usually after hospitalizations or physical or mental illness. Imposed on another, the same, that one is typically after hospitalization of child or dependent, same type of thing. So let's say a person goes to the hospital because they have cancer, something legitimate, and then they come home and then all of a sudden they're like, oh, I have cancer again, and they're just making it up when they really don't. So that's what that's talking about. The range of symptoms can be pretty wide. You can just have complaining of illness, or falsifying information, and you're just like, oh, I have a chronic headache or something like that, when really you don't. Or it can be actual physically inducing an illness, like scratching the IV site, or taking pills to give yourself diarrhea or vomit, something along those lines. That is the more extreme of it. So there might be some crossover with like self-harm, and people might think it's that, when it could be factitious disorder, or vice versa. The cause, there are like three main views on it. There's the psychodynamic one, which is saying that there's underlying stress, or an underlying problem probably from childhood that is causing them to do this. It could be a defense mechanism of some sort, where like maybe they were abused as a child or neglected, but then pretending to be sick or something like that stopped the abuse or neglect. It could also just be attention-seeking behavior. Maybe they grew up in a house with a lot of kids and they weren't given much attention or something, so they pretended to be sick quite a bit. That could be it. The behavioralists, they focus more on the rewards, which isn't, as we talked about earlier, there aren't external rewards to this. There might be internal psychological ones, just the simple fact that they're getting medical attention might fulfill some need or want that they have. Now the cognitive one is just that it could be trying to convey extreme emotion of some type. Again, as I talked about, there could be abuse and neglect early on in the child. Typically, if someone has factitious disorder, that is common, where they were abused, they were neglected, they have self-image problems. Things along those nature are typically common in people with factitious disorder. This is kind of a chart or a graph showing about like the unconscious and conscious version of it. So you have early deprivation or trauma, suffering provide meaning to life, so that's the unconscious, and then an emotional distress, so that might be like the hospital or something like that, going into and then leaving the hospital, and then inducing or faking an illness and going to see a doctor all the time. That's the conscious manifestation of it. And then after that, a release, that could be a relief of emotional stress. The course, typically it's intermittent episodes. So single episodes aren't very common, but it does happen. Persistent, it's not like they're going to be doing it for like years every single day. It's just kind of intermittent here and there. And unremitting, they aren't as common. Generally, the people with factitious disorder are lost to follow-up, hence why it is tough to get an estimate on how many people actually have it, because they'll go to a doctor, the doctor will do tests, figure out what's going on, and then they're like, you don't have or you don't have cancer, your bone's not broken or something like that. So the person's like, oh, all right, and then they go to a new doctor. A lot of these people are actually really common to go through some painful treatments just to get it. It's really interesting. As I mentioned, these people are quick to leave, which makes it difficult to get an estimate on it, and also to get some good research and data on like treatment for it. Some differential diagnoses. So you have somatic symptom disorders that you might confuse it with, but for that one, those are real pains and aches and illnesses and whatnot that appear in the person. They're not made up. Like if someone has back pain because of a psychological problem, they actually have that back pain. With factitious disorder, they don't have it. It's all made up. Malingering, like we talked about earlier, just making up the fact that they are sick. It's obvious that it's different in the fact that there's no external reward for factitious disorder, whereas malingering, there is some type of reward for it. As I talked about earlier, there might be some personality disorder stuff present, but that's not as common. Treatment and prognosis. So, as you can imagine, it is challenging to treat. Therapeutically, since they're flighty, it's really challenging. The best way that research says to do it is like have non-threatening but direct discussion with them. In order to do that, first you need to have a strong therapeutic relationship. That's pretty obvious. You can't just right out of the gate be like, hey, you have factitious disorder, let's talk about it. They're going to be like, heck no, and then they're going to leave. So you need to develop a bond. The analytical and cognitive approach, or cognitive behavioral approaches, seem to work the best, uncovering the unconscious problem and talking about that, the root of it, will help, as well as talking about like the cognitions and behaviors behind it and trying to address that. Interestingly enough, therapy for a comorbid disorder, like let's say they come in with a generalized anxiety disorder, and then along the way it is uncovered that they have factitious disorder. If you treat both of them kind of at the same time, it'll help a lot, because they will stay in therapy for generalized anxiety, and then along the way, if the therapist addresses factitious disorder, it'll go away. With therapy, factitious disorder does seem to lessen and go and become better, but as mentioned, it's tough to keep them in therapy, especially if they just have factitious disorder, because they just want medical treatment. That's all they do. They don't really want like to be done with factitious disorder. This is kind of just a general table talking about the confrontation of it, the procedure of how to do it. So if you just want to go ahead and look at this for a little bit. But yeah, that is it.